We are live.
Good evening. Welcome to our Saturday evening webinar, Walk-in Patient Series. This is a very popular series of webinars which is mainly aimed at general ophthalmologists and early career specialists. It usually addresses certain topics of general interest. And today we are addressing normal tension glaucoma, which can sometimes cause problem in diagnosis and management. So topic for today's webinar is walk-in patient with normal tension glaucoma, how to diagnose and manage. The session will be chaired by our new president, Dr. Pathophysiology, who is the medical director of Trinetralaya, Kolkata. Dr. P. Satyan, who is also the president of Glaucoma Society of India. He is from Coimbatore. And Dr. Roni Jaj from Shankar Netralaya, Chennai. Program director and moderator is Dr. Shweta Tripathi from Indira Gandhi Eye Hospital and Research Center, Lucknow. Mona Khurana from Shankar Netralaya, Chennai. And Manoj Mathur, who is from Hyderabad. He's also the treasurer of AIOS. Panelists are eminent, and it consists of Dr. Manish Shah from Agarwal Eye Hospital, Mumbai, Dr. Chandrima Paul from BBI Foundation, Kolkata, Shibal Bhartiya from Marengo Asia Hospitals, Gurgaon, Subhashini Kalyaperumal from JIPMA, Pondicherry, and Dr. Gur Satinder Singh from Adesh Medical College, Ambala. We have 6 presenters today. Apart from moderating the session, Shweta and Mona will also speak. And that apart, we have Shefali Parekh. She's from Shriji Eye Clinic and Palak's Glaucoma Care Center, Mumbai. Sushma Tejwani from Narayan Netralaya, Bengaluru. Shahinur Tayab from Shankar Deva Netralaya, Guwahati. And Dr. Vinita Ramnani from Bansal Hospital, Bhopal. And that's the list of talks that we have today. And it is going to be interactive with a lot of discussion in between each talk. And most of these talks are case-based. I invite our new president, Dr. Partha Viswas, to share his thoughts and make opening remarks.
Thank you very much, Santosh, and thank you for the kind introduction. So the walk-in series is very, very vibrant and a very popular webinar that has been there for a very long time. And this and the one today that we are going to discuss, the normal tension glaucoma, which is something of an enigma for most of our general ophthalmologists. That includes me as well. So it will be a real treat for everyone to understand, know, since this particular entity of normal tension glaucoma or low tension glaucoma has some characteristics with the open angle glaucoma, which is common, yet with a intraocular pressure within the normal range. It is a progressive disease and it can cause blindness and bilateral blindness. And this is sometimes what we actually face, and it definitely needs a lot of attention, and especially from the pan-ophthalmologists, people who actually are in the front line of first diagnosing that this patient is a glaucoma patient. That becomes a domain of the general ophthalmologists who first detect it and then see the progression. And when the progression is occurring, yet the intraocular pressures are within normal limits, that's when we definitely need a second opinion, a specialist opinion, and that's when we should refer the patient and seek a next opinion. So thank you very much. We look forward to a very, very interactive discussion on this very important subject. Thank you, Santosh.
Shweta, please take over.
So, shall we start, sir?
Yeah, please take over. Yeah, go ahead.
Yes. So, at the outset, I'll take this opportunity to thank AIOS for giving me this opportunity for conducting the webinar. A warm welcome to all the esteemed chairpersons, panelists, moderators, speakers, and the AIOS office bearers. So, when we talk about NTG, the first thing comes in my mind is it's a significant controversial topic as it is a spectrum of POAG or represents heterogeneous diseases. The impact occurring from asymptomatic disease to causing the bilateral blindness. So today, with this eminent group of speakers, chairpersons, and panelists, I'm sure that at the end of the webinar, we are going to give a lot of take-home messages which will help us to decode all the challenges of normal tension glaucoma. With me, I welcome my co-moderator, Dr. Mona ma'am, who is going to take and who is going to co-moderate with me. With this, I invite my first speaker, Dr. Shahinur Tayyab, to share her screen and start the presentation. Dr. Shahinur.
Mute yourself, Shainu. Yeah. A very good evening. This one. Yeah. So is my screen visible?
Yes, Shani.
Yeah. A very good evening to all. I'll be talking about all that we do not see in normal tension glaucoma. So, normal tension glaucoma, as we know, is a chronic but slowly progressive disease. We often become complacent in managing these cases. So that is why I'll be presenting two simple cases of normal tension glaucoma just to highlight the fact that at all points of time, we need to be very vigilant in managing these cases so that we do not miss out the subtle changes that might be occurring. So my first case is a 60-year-old gentleman who had presented to us in 2013. He was diabetic, and at the outset, his intraocular pressure was 16 millimeters of mercury. So on clinical examination, the best corrected visual acuity was 6.6 and 6 in both eyes. The slit lamp findings were unremarkable, and the IOPs were within normal range of 16 millimeters of mercury. And gonioscopically, it was open. And the disc, the right eye was noted to be healthy, but left eye, there was a suspicion of glaucomatous optic neuropathy. So a DVIOP was done, but there was no significant fluctuation. However, the patient, these are the fields of the patient in which we can see there is no significant glaucomatous optic neuropathy changes. However, based on clinical suspicion alone, we had started this patient on brimonidine tartrate and thrice daily. But the patient did not come for follow-up for the next 2 years. When he did come, we could see some definite inferior field defects in the left eye. Treatment was initiated only to the left eye. So in 2015, when he developed significant changes in the definite changes in the left eye visual field, we changed the medication from brimonidine to bimatoprost. Again, the patient did not follow up for the next 1.5 years. In 2018, when he came, the intraocular pressure was 14 and 15 millimeters mercury. Because we had changed from paper to EMR files, the previous corneal thickness that was measured was lost. So again, we did the CCT, and at that time, we noted that the corneal thickness was also low. This is the retinal ganglion cell we had assessed, and you can see that the left eye shows significant loss of the retinal ganglion cells corresponding to the clinical optic nerve head findings. And the IOPs were still 14 and 15 in the right and left eye with medication only to the left eye. You can see that the right eye showed no loss of the retinal ganglion cells. In 2021, the patient used to come for yearly checkup. So in 2021, again, OCT RNFL was done. Intraocular pressures were 14, medication only to left eye. And you can see here that the right eye OCT showed no loss of the double hump pattern, or there was no thinning of the retinal nerve fiber layer. In 2022, we did the fields, and this time round, we can see that the right eye also showed some early field defects in the inferior hemifield. IOP was 14 and medication was still only in the left eye. However, clinically, the disc was noted to be healthy, and because the previous year the OCT showed no thinning in the RNFL or borderline RNFL thinning, no action was taken for the right eye, and he was continued on AGM only in the left eye. Then again, he came back the next year. He used to come every year for follow-up. So this time the IOP was noted to be 16 in the right eye and left eye 14 millimeters of mercury. And he was also recently diagnosed with hypertension and started on medication. So when we did the OCT RNFL, this time we could see that there was a dipping in the superior RNFL. A field was also done, and this confirmed and consolidated the defect in the right eye. So this time we started bimatoprost in the right eye as well. So the final checkup in 2024 when he came, he had developed some cataractous changes also. And with medication, bimatoprost in both the eyes, the intraocular pressure was 11 in the right eye and 12 millimeters of mercury. And now we could detect the glaucomatous optic neuropathy changes in both the eyes. Unfortunately, I do not have a disc photograph in this patient because of the transition of file from paper to EMR files, but the clinical findings were noted as such. And the left eye also showed some beading of vessels, for which we consulted with the retina department, and the hypertensive retinopathy changes were confirmed, and the patient was continued on anti-glaucoma medications in both the eyes and asked to review for 6 months. So what I wanted to emphasize with this particular case is that each time to reduce the burden of cost, the patient was advised either a OCT or a field, not all together. And clinically, because the discs were healthy, noted healthy in the right eye, so we did not ask for all the tests together. So it was done one at a time. But eventually we saw that the field test was picking up the defect, although clinically the disc was healthy. So what I want to say is that we should be very careful in following up this patient. We should not become complacent. Coming to the second case, this was a case, a 72-year-old gentleman. He also had presented elsewhere in our locality, but diagnosed elsewhere with a baseline IOP of 17.3 millimeters of mercury. And he was started on travoprost eye drop to both the eyes. These were the fields from his visit when first diagnosed elsewhere. So we can see a paracentral defect in the right eye, and in the left eye we can see early superior, more like a secocentral kind of defect in the left eye. The fields also showed thinning of RNFL. The patient used to follow up, but again we were still having the paper files, so the old records are not there. So recently he has come again in 2024. Now he was on treatment in both the eyes. A fixed dose combination of travoprost, timolol, maleate was going on, and brimonidine tartrate twice daily. He was hypertensive and he had also undergone angioplasty, and he was on medication. So on examination, the slit lamp findings were unremarkable. Best corrected visual acuity was 6.6 and 6, and the intraocular pressure was 15 and 20 millimeters of mercury in the right and left eye. The optic nerve head showed gross cupping with 0.9:1 CDR with inferior RNFL defect in the right eye, and the left eye showed 0.9 cupping with inferior rim loss and inferior RNFL defect. CCT was also low in this case of 445 and 455 microns. This is the disc photograph, and we can see he has got advanced cupping in both the eyes. These are the fields which were done in 2024 September. So the IOP being higher on the left side, we modified the treatment. We changed the brimonidine alone to a combination of brinzolamide, brimonidine, fixed dose combination, and netarsudil was in addition added to the left eye. The patient reviewed back again after 3 months, and this time the IOP was noted to be 15 millimeters of mercury and 13 millimeters of mercury in the left eye. He was advised to continue the same, but he came back after 2 months with complaints of irritation, redness, and watering in his eyes. He had stopped netarsudil eye drop, and the other two fixed dose combination was going on. The intraocular pressure was 12 and 10 millimeters of mercury, and there was conjunctival congestion. We could see that he had developed allergy to the anti-glaucoma medications, so all agents were stopped, and he was put on oral acetazolamide in BD doses. These were the fields that were again repeated at that time. And when he came back after 4 days, he was symptomatically better, but the surface inflammation was still there. The conjunctiva was still congested. So we started a weak steroid for him in tapering dose, and Diamox was continued for another 2 weeks. He was also advised for trabeculectomy once the inflammation subsides. So after 3 weeks, he underwent trabeculectomy in the left eye, and post-operatively he received prednisolone acetate 2 hourly and moxifloxacin in the left eye. On the first post-operative day, the IOP was 17 millimeters of mercury in the right eye and 13 millimeters of mercury in the left eye. But by fifth day, the right eye IOP had increased to 24 millimeters of mercury. There was no AGM going on in the right eye, and IOP was not noted high in any of the previous occasion. So was it a steroid response? We started him on lapnoprost eye drop, and at 3 weeks post-operatively, the left eye vision was 6.9 and IOP was 11, and in the right eye, the IOP was 17 millimeters of mercury. So here I was a little confused. So was it really a steroid response, or was the diagnosis initially missed? A POAG was wrongly labeled as NTG. But going by the investigations that he was carrying from his first visit of diagnosis, we could see that the central field was more affected. So that goes more in favor of NTG. But how often do we get steroid response in normal tension glaucoma? Thank you.
Thank you, Dr. Shainur. It was a nice presentation. So I would request Dr. Chandrima ma'am to just share her insight that how frequently should we follow up regarding the first case? How frequently should we put the patient on follow-up so that even if we are expecting any kind of structural changes before the functional changes, then the disease is caught in time so the timely intervention can be done.
Good evening, everybody, and thank you, Dr. Shweta and AIOS, for this opportunity. So that was a brilliant presentation, as always, Shahinur, and two very interesting cases. So to talk about the first case, actually, normotensive glaucoma is basically a diagnosis of exclusion that we do. And I think everything possible was done in that case, except maybe the patient could have been checked for blood pressure, because since the patient on the last visit, if I remember well, had hypertensive retinopathy. So that must have been a long-standing hypertension which the patient had. But I think that was not checked initially when the patient came for consultation. So when you actually label somebody as normotensive glaucoma, I think it's wise to see the blood pressure, because the blood pressure has a big role to play in normotensive glaucoma, going into the paraphernalias of ocular perfusion pressure and the rest of it. And to come to your question is how often should you follow these up? So that would actually depend on whether the patient is progressing or not. If the patient is progressing, well, we definitely ask for a quicker follow-up, say 4 months. Every 4 months we follow up with fields, and if possible the OCT, and definitely disc photographs, because stereoscopic disc photographs would rule out the observer variance and all that. And if the patient is not progressing, then we can of course ask the patient to come 6 monthly. That's twice a year. So that's about the first case. So maybe if we had looked for hypertension initially, so we could have thought about ocular perfusion pressure and the rest of it. Though, of course, there's not much we can do to treat ocular perfusion pressure, but at least we can have a word with the cardiologist not to, monitor the BP and not to give medicines in the evening, so that there's a further lowering of perfusion pressure at night, basically. So that is
Right,
it.
Right, ma'am. Thank you, ma'am. So my next question would be with Manish sir. Manish sir, if you see that your patient is progressing structurally and functionally they are stable, so how often would you like to put the patient for stepping up of treatment just based on the structural changes or the progression?
So basically, I would decide on the clinical picture, and basically when you see, you do perimetry and you do OCT and you do the ganglion cell also. And as your question says that the progression is detected only on structural, means I suppose you see it on the ganglion cell and the RNFL analysis, but the perimetry is pretty stable. in such a scenario, if I am convinced from the clinical exam also, because besides the test, when we see the optic disc, and as Dr. Chandrima pointed out with the 3D photograph or the stereoscopic photograph, if you find clinically also that structurally it has gotten worse, I would definitely step up the treatment, because perimetry can take a little longer time to show the change. And perimetry is subjective also. Sometimes you get variations. I wouldn't want, and if, as in normal tension glaucoma, if the field defects are close to fixation, which they usually are, then you don't want to take a chance. So stepping up treatment definitely in the form of stepping up medications. Whether I would immediately go for a surgical option is not so clear cut, black and white. I would prefer to just step up medications if that option is available.
Right, sir. Thank you very much, sir. And my third and the last question for this case would be to Ronnie, sir. Ronnie, sir, it says that the diurnal variation test, the role of diurnal variation test in normal tension glaucoma, it does shows the fluctuation. Now, is literature, sir, shows that if the larger the diurnal variation test is, the more there are chances of progressing in that particular NTG. So, what takes can we take from this literature search or the literature which says that higher the DVT, higher the rate of progression? Is it correct?
Well, see, the thing is,
stop sharing
NTG is part of the POAG spectrum. So many of the patients with NTG actually have POAG. If you look at Shainor's second case, towards the end, the pressure was 20 on 3 drugs with a factor of 455. So that's a patient who's more likely to be POAG rather than NTG, because the baseline medication had been started with a SHOS intraocular pressure of 17.3. So the increase in fluctuation is probably in patients who are closer to the POAG spectrum. And let's not forget that NTG patients are essentially do have a pressure sensitive component. It's just that they're sensitive at much lower pressures.
Right, sir.
And the steroid induced, you had spoken about the steroid induced response in the fellow eye Shainu. So we have a paper in IGO when we looked at about 300 traps, and we found that in 20% of eyes, you got a steroid response in the contralateral eye, more than 6 millimeters of mercury. That's again commoner with POAG than with NTG. So the second case I would put closer to the POAG spectrum rather than the NTG spectrum.
Sir, and one more question in continuation of the same thing. You said that these patients are more prone for a faster progression. Should not be the target IOP set on a lower level when we see the larger fluctuation? So then can we titrate the target IOP, sir, on a much lower level, going for the, instead of teens, going for single number?
It's very difficult to achieve single numbers with medication alone. And if you look at Shainu's first case, you saw progression after almost 10 years of work.
Right, sir.
So it's a very, very slowly progressing case. You have lost nothing in that patient. In 10 years, actually, barely any functional loss. So you have to put everything together and then decide how aggressive you need to be.
Right, sir. Right, sir. Thank you very much, sir. And with that, I call upon my co-moderator, Mona ma'am, to moderate the second case.
It's my pleasure to ask Dr. Vinita Ramani to share her experience with NTG with us, and we're looking forward to your case.
Thank you. Thank you, Shweta and Dr. Mona and AIOS for giving me this opportunity. I will be, hope my screen is visible. My screen is visible?
Yes, it's visible.
Okay, so I will start with NTG case, which is a clear-cut demarcating prototype case. A 67-year male came to my hospital for taking a second opinion because he had some doubt about the glaucoma at first examination, case of hypertension, but well under control. There was no evidence of any cardiac event or a family history of glaucoma, trauma, migraine, sleep apnea, or diabetes, which was not there. HbA1c of 5.9. So on examination, though he was hypermetro, but the best corrected visual acuity was 6.6 and 6 with the normal anterior chamber depth in both eyes with the early nuclear sclerosis and an applanation of 12 millimeters of mercury without any medication. And the gonioscopy was open with a narrow entry and the CCT of 554 and 555 microns. So this was the examination he was carrying along with him from the first examiner, which is 2 months earlier to this examination. So this is the fundus photograph, which definitely shows that something fishy is going on in a right eye. The OCT macula was done, which was normal, and definitely a corresponding RFNL defect, which was seen in the OCT pictures also, both in GCC and a RFNL map. And this was his fields, which was done 2 months prior to the first examination, which I will be showing my examination. This doctor has done a diurnal variation, which was between the 14 to 18 millimeters of mercury in the right eye, and in the left eye, 14 to 16 millimeter of mercury. And the CT had an orbit was done, which was normal. So looking to the previous examination, what we can gather is that IOP was 18. That is definitely an inferior RFNL defect, which is seen well on the fundus photograph, and a corresponding field defect, which is central, more so in a right eye, and left looks practically normal. So let us see what the examination at my center shows. So this is the fundus photograph. You can see that there is a definite field defect and the definite RFNL defect, which is seen in the inferior part in the right eye, and the CD ratio was 0.6 in a medium-sized disc, which was vertically oval. So have a closer look, and you can definitely see very well fan-shaped typical defect, which is seen in the inferior part, and the left eye, which looks practically a normal healthy neuroretinal rim with CD 0.4. And on a closer look, upper part of the left eye even showed some kind of an RFNL, the retinal nerve fiber layer defect superiorly, but maybe some artifact, or it remained same. I will show later on. I subjected the patient to the OCT, and which is definitely showing a corresponding loss in the RFNL in the inferior quadrant, and which is very well seen on a GCL map. So there is a typical field effects which are seen as in NTG patients, and the left eye, which looks practically normal on OCT RFNL map as well as GCL map. So this patient on a perimetry 2 months down the line, the first perimetry was done. Look at this, there is a central scotoma, and as there is an importance of 10-2 program in such patients, you can find out a clear-cut central scotoma well sitting in the upper part of the field in the right eye, but the left eye remained normal as far as the disc, OCT, and fields are concerned. So I did an ECG echo for this patient and subjected to carotid Doppler, which looked normal. So everything was under control. So I discussed with the patient the pros and cons, and then tell him to follow it up down the line 3 to 6 months. So he came 1 year down the line. The picture practically in the right eye looked the same. So this is the fundus photograph 1 year down the line. And OCT this time, rather, the RFNL was tagged yellow, but though there was a definite RFNL loss, and the fields were practically same down the line in the right eye. And the left eye remained same, no change at all with the normal OCT and HVA findings. So 1 year down the line, this patient did not show any progression. So again, I spoke to the patient that your disease is not progressing and your intraocular pressure is 12 millimeters of mercury. What we should do? So we decided mutually not to treat and follow it up. So now see the follow-up 8 months after the 1 year follow-up. So the 18 months, now you can see definitely a nerve layer defect. On top of it, there is a splinter hemorrhage, which is characteristic of an NTG patient. So the right eye showed an hemorrhage, which I was lucky enough to have that hemorrhage in that particular time to diagnose. And because of that, the OCT showed little bit of the fluid. So even that OCT inferior aspect showing the nerve thickness, which is little more in comparison to the previous one because of the splinter hemorrhage. But then practically the perimetry remained same, which was there 1 year before. And the left eye showing the similar thing 1.5 years down the line, no change, practically normal. So this is the over the years, the changes which are happening. So If you see the first photograph is on presentation, then 1 year and 1.5 years. And this is like in the color red-free photograph, you can see that fan of that retinal nerve fiber defect is little bit expanding. So maybe a slight progression if you measure all three together in comparison to the nearby blood vessels. And the left eye practically remained same. There was nothing changed in the left eye, which is showing the similar presentation. But because of the presence of the hemorrhage, this time I decided to treat, but I decided to treat in both eyes. Probably I could have done in a then he started putting the drops in both the eyes, and I asked him to come for the follow-up. So this is his recent follow-up, 2.5 years after the first visit. The refraction remained the same, but this time the nuclear sclerosis has increased a bit, and then he has come down to 6.9 vision, though he didn't complain of any problem as far as the vision is concerned. And practically the applanation remains 12 also, even on the travoprost. And I have seen in the different timings also, practically every time he doesn't come on the same time. So on a follow-up visits, the IOP remained 12 only. The picture in the right eye and the left eye, I didn't find any change much except for that widening of the nerve fiber layer defect, which is present inferiorly. And left eye remained same. And this is the 2.5 years down the line from the first perimetry showing same, even the GPA showing the same. And the left eye didn't show any problem from the beginning, and it remained same all throughout. So the key characteristic of the NTG, which fits into my case, is that the IOP remains normal, open angles, progressive optic nerve damage, and the field effects, which are deeper, steeper, and closer to the fixation. And basically, we all know that the theory for this is a vascular dysregulation, which is the major attributing factor, but there could be a pressure difference between the inside and outside of the optic nerve, which makes the optic nerve more sensitive to the damage, and so also the structural weakness of lamina cribrosa. So we know there are so many other factors has been put forward, because not one, there are so many factors. So some oxidative stress, metabolic disorders, or genetic predisposition may lead to a NTG, and these are the risk factors for the patient which we were discussing, that nocturnal hypotension and the thin CCT. So it's basically what Dr. Ronnie says, it's a spectrum of POAG only. And there are many studies which shows that 24 to 32% of the cases, they have a lower baseline IOP on presentation. So they started as an NTG, and probably with the increasing expectancy in the life, we will see more and more such type of the cases. So we should differentiate it from the other glaucoma. And as Dr. Chandrima said, it is a disease of exclusion. So you should exclude the POAG with the thin cornea, which Shainur has as a second case, and maybe some cases which may show a temporary low IOP that you should be keep in mind. And the most important is many of the doctors, they are in a hurry to diagnose NTG, and they mislabel a different kind of an optic neuropathy as an NTG. So one should rule out all the causes for the non-glaucomatous optic nerve changes. And as far as the management is concerned, probably you have to just follow it up in the initial cases, in a mild, moderate cases. But then if it is a severe cases, you can decide treating on upfront. 65% of the cases in CNTGS study did not show any progression in 5 years. And just monitoring, and then once you confirm that it is progressing, you can start treatment. And optic nerve hemorrhage is considered as a main cause for the progression of such patients. We can lower the IOP to the extent of 30%. So we have to aggressively lower the IOP. And even in the CNTG study, 12% of the treated group, in spite of their treatment, they showed the progression, because we all know it is some non-IOP related factors which are more playing into the NTG patients. So we can start with prostaglandin analog to start with, and then see the effect. Maybe a brimonidine and dorzolamide can give a little bit of an increased blood flow and neuroprotection. And we always should think of a non-IOP independent treatments also. So look for hypertension, get a dietary supplement, If the patient is having an obstructive sleep apnea, you should treat it. And exercise, yoga, meditation plays a very important role in such patients. As far as my case is concerned, probably I would like to discuss that whether we should treat left eye, and do we still need to keep IOP even low? Because surprisingly, the pre and post treatment IOP remains 12. So should I change the drug? And what could be the follow-up of my case? Like, we are all talking about what should be the normal follow-up. Now stick to this case, that how frequently I should follow this case, and what could be the follow-up strategy. It is only OCT, only HPF, both are one at a time. And can we do anything special for this case? So thank you so much for patience listening. And I invite all of you for this Glaucotol conference, which is happening at Bhopal between 13th to 14th of September. So see you all at Taj. And thank you so much, Dr. Shweta and AIOS, for giving me this opportunity.
That was a wonderfully documented case, ma'am, with the classical wide field imaging of the RNFLDs and a beautiful disc hemorrhage, also showing the importance of doing a 10-2 and how OCT, like in the left eye, can lead to a green disease. So at this point, let me refer your questions to Dr. Shibal, ma'am, and starting with how often would you do a DVT in these patients, especially when you see a disc hemorrhage?
Believer in diagonal curves, so asking me that question is rhetorical. I would never ever want to diagnose a normal tension unless I have a diagonal variation curve. And which is my, if you do enough diagonal variation curves, you will realize that you have very few NTGs in your practice.
So once you diagnose them, then do you do it during the follow-up also? And how often when you're treating them? Do you look at how the IOP reduction and the reduction?
I would do a DCT, a diagonal control curve as well, which means the first follow-up when you're looking at your pressures, and thereafter once a year if time and energy and resources permit.
So another question is that now after the light trial in POAG, we are offering primary SLT. So what about our NTG patients? So do you have any experience with that, or what do you think of the literature on that?
Okay, so I wouldn't be able to answer that with any degree of personal experience because I would hesitate in offering it as a primary first-line therapy to my NTG patients because, you know, when you have very low pressures, you are setting yourself up for failure in SLT in very many ways. But treatment-naive eyes tend to do better. Eyes with thinner corneas and higher pre-treatment IOPs tend to do better. So in those particular subset of a subset, you might want to consider SLT because the evidence does say that SLT works also in NTG.
Thank you so much for your comments. Dr.
Sorry, I was just going to add a little thing is that, you know, when you look at these historical cases, Shahiner's case, the first one was like, typically focusing on the logits because they were talking of brimonidine, and as you know, as evidence has changed, more and more newer modalities are coming into play. So maybe 5 years from now, people will talk of SLT as first line, just as we're talking of prostaglandins as first line and not brimonidine anymore. So the jury is still out there.
So, Dr. Subhashini, so what would be your first and second choice of treatment in patients with NTG?
Yes, Doctor. First of all, I would like to thank Dr. Shweta for including me as a panelist. Dr. Vinita, ma'am, has beautifully presented. Just wanted to tell the same thing, well-documented case. Actually, this patient is 67 years old. So, and then everything was favoring normal tension glaucoma, except that the asymmetry. So much of asymmetry is there. So in this case, it's clear cut. It's more like NTG. But otherwise, for the audience, what I would like to say is when it's so asymmetrical, so we need to go for other findings, and in fact, a CT or MRI would help. So going to your question, so what would be the management? So in this case, I felt the presenting intraocular pressure also was in the range of, in the early teens. It was 12, if I'm right. Yeah. So, and then with that pressure, the patient developed an optic disc hemorrhage, and which means that that pressure is the eye is not, the optic disc cannot sustain that pressure. So I feel we need to lower the pressure further. So, and madam had actually rightly started the patient on prostaglandins. Prostaglandins are the first choice. So, and generally aqueous suppressants are not preferred because the aqueous secretion itself, it reduces during the night time. So, these aqueous suppressants might not be that effective when the nocturnal hypotension happens during the night time. So, the prostaglandins would be my first choice. And in this case, with the pressure was actually, there was no change with the prostaglandin. Travoprost was started and the pressure did not reduce, then I think we need to step up the treatment, or in fact, consider even a trabeculectomy to get the pressures much lower, because it was the serial documentation showed definite evidence of progression in the right, and though in the left it's a bit slow. So, but and madam has rightly started the patient on travoprost in both eyes. That's a very good thing to do. Uh, my second choice, I don't have much experience with SLT. So I would, maybe that could be an option. And, or if the patient is developing cataract, then you can combine it with a MIGS. That's an option. So, but prostaglandins would be the good choice because they have a good 24-hour intraocular pressure control.
Thank you for your comments. So I'd like to ask Dr. Ronnie George for his comments. So if we need low IOPs and this patient also has a cataract, so would you go for MIGS, or you would combine it with a trab, or you would just do the cataract?
If I'm looking at medication, I might consider switching the prostaglandin, because you didn't see much of a response with one, you might try another one. But if I'm going to do a cataract surgery on this person, I would combine it with a trab and not really a mix, because you're looking at single digit intraocular pressures. You want something a little bit more predictable here. Having said that, I agree with the decision to treat the other eye, because you had an NFL effect on the right eye progress. So, I would have done the same thing.
Dr. Ronnie, will you shift it to another prostaglandin, or you will shift it to the carbonic anhydrase inhibitor or something like that? If the patient comes to you, what will you do? Because once I started travoprost in this patient, he had come yesterday only. It's a finding of 10th. So I told him that let us wait. I have to do something for you because travoprost is not working. So in that case, I think a shift of prostaglandin to the other molecule are definitely to the carbonic anhydrase inhibitor.
The reason I'm saying shift is because we didn't see anything in any change in the intraocular pressure. It was 12 and it is still around that. So sometimes you do get non-responders to one molecule. It's worth giving it a try, because in terms of convenience, the prostaglandin works the best. If you get 2 millimeter intraocular pressure drop, you're happy with it. So if that doesn't work, yes, whatever else, I mean, you use is fine.
And anything against adding temolol maleate by any chance for this particular patient?
See, the thing with temolol is, there are concerns that it reduces optic nerve head blood flow, but that's not strictly true. So, and also with almost all the glaucoma medications, with the exception of the prostaglandin, you really don't get below the epicleal venous pressure, which is in the range of 8 to 12. So adding on something else at this point, you're really not going to achieve very much more in terms of intraocular pressure reductions.
Thank you.
With such asymmetric disease, you may want to look at the carotids and look at what is happening there as well.
I did carotid Doppler. It was normal. I did ECG, echo, and carotid Doppler on the first stay only.
Maybe again.
Yes. I don't know why he's having that asymmetrical presentation. And probably if you see 2.5 years down the line, he's same, not going anywhere. Only thing is just an hemorrhage, which just came into, maybe because of hypertension, I don't know. But then even that, he himself is a doctor, the patient. So the blood pressure is quite well under control.
So one option is to do a 24-hour blood pressure monitoring, because nocturnal hypotension can cause this to happen. And about 20% of NTG patients are night dippers.
Yes.
So if you're night dipping, then bleed is one of the.
And I would repeat the gonioscopy as well.
Yeah, I did. It is
You're
open.
repeating it? Okay.
Yes. So every time, whenever he is coming, I have to scratch my mind that what has happened, because he himself is a doctor. So I have to think again why there is an asymmetrical presentation. Why, like for the first time I treated, and then I called him yesterday just for the sake of presentation. I said, you come and let us see that whether that travoprost is working for you or not. And surprisingly, the pressure remained same. I think that Holter monitoring of 24 hours blood pressure is the one we should do in this case. But then the left eye is tough enough to get that even nocturnal hypertension not affecting that left eye.
Yeah, so not yet, because see, there can be very local factors which matter, and very often POG is asymmetric, NTG also can be asymmetric.
Yeah.
That was an interesting discussion, and good luck with your patient, ma'am.
Thank you.
So with now, I'll ask Dr. Shweta to moderate the next case.
Yes, just a question to Satyan sir, ma'am, regarding this only. So it was mentioned that the disc hemorrhage is supposed to be one of the most important indicators for the disc progression or the disease progressing. So how often it's recommended to follow up the case with the visual fields if once the disc hemorrhage has been seen? Satyan sir?
Thank you, Shweta. First of all, my sincere apologies for joining later. One thing is, first, the disc hemorrhage, is it really a hemorrhage because of the NTG, or is it because of something else? Has to be ruled out. And once you see that the disc hemorrhage leaves the NFL loss, that is most likely the possible cause for the progression in NTG. If it doesn't leave, then it could be because of diabetes, hypertension, or other reasons could be the possibility. So it takes about 6 to 8 weeks minimum, or it takes even 3 months for the absorption of the complete hemorrhage to happen. So you see that and then observe how, how the pattern is, and then you can, based on that, you can do the follow-up. And we know, all of us know that in NTG, the hemorrhages are a good possibility, but always remember that other associated diseases like hypertension and diabetes can play a role. So that is one thing. Having said that, it is not only the hemorrhage which you observe, looking at the RNFL pattern. So in the RNFL pattern, if you start seeing there is a bilateral symmetrical RNFL pattern, and if there is a non-progressive disease, but it definitely has a visual field defect, then what we are most likely seeing could be the cerebral stroke. So last week we had about almost 3 patients whom I have seen that symmetrical RNFL loss with the inferior notch and everything, but symmetrical, a typical cerebral stroke. So not all RNFL loss starting from the disc margin is NTG. If the IOP is normal, it doesn't mean it is just NTG. It could be the MS, it could be the cerebral stroke, but there's a high possibility of the cerebral strokes. But that will also give you the RNFL loss only at the end of 12 weeks. So just take a note of the RNFL pattern and look at other causes also. Is it really an NTG that we are seeing, or is it something else that we are seeing? So that is very crucial.
Yes, sir. Thank you very much, sir. So with that, we invite our third speaker for today's webinar. That's Dr. Sushma Tejwani, ma'am. Sushma, ma'am, please share your screen.
Okay, good evening. And thank you for the opportunity, AIOS and Shweta. I hope you're able to see my screen. My screen is visible?
Yes, sure, so sure.
Okay, so I'm going to talk about two cases which indicate that whether its NTG is also related to optic nerve head perfusion and oxygen. So we all know that IOP is only a modifiable factor, but we do have patients where IOP is normal and progression happens despite of good IOP control. So definitely there is something else which is playing a role, which we are not able to pinpoint many times. So there are multiple non-IOP related factors that we have discussed and we are going to discuss. So I'm just going to talk about a couple of cases. So one, which is related to the pathophysiology of normal tension glaucoma. So since it's a multidimensional disease, we know there are non-IOP related factors. We know there are systemic factors. There are other things like IOP and biomechanics change. There are neurodegeneration factors, defective autoregulation factors, and it's a big spectrum. So let's look at a case. This is a very young gentleman, 35-year-old, and had absolutely normal vision 6.5 N6. Pressures were 16 millimeters of mercury with the Pachy of 543 and 534. And you can look at the optic nerve. This is how the optic nerve looked like. He already had a superior notch, a definite RNFL defects. And this is actually one of the cases that was picked up by one of our postgraduate students during a company camp when they go for, refraction check and just a direct ophthalmoscope. So that's how he came to the hospital. And this is how his visual fields were. He had no idea about glaucoma, no family history of glaucoma, such a young gentleman. And this kind of field defects is what he had, including the central fields. This is a 10-2 of right eye and left eye. When we did the OCT, that showed corresponding defects, superior as well as inferior RNFL defects in the right eye and the left eye. So definitely working diagnosis was normal tension glaucoma, but this was just on the clinic working diagnosis. So I advised for a full day diurnal variation and the systemic evaluation to look at what is happening. So when we did full day DVT, in my practice, when I do a full day DVT, I always do a blood pressure along. So his highest IOP was 19 and 20 millimeters of mercury actually. So it was on a higher borderline range. And BP was pretty okay, not major fluctuations, 120/80 to 130/90. The other things, color vision and contrast were normal. There was no history of any systemic issues or snoring or Raynaud's phenomena or any other illness for that matter. So we did label him as normal tension glaucoma and advised workup. Started on prostaglandin because there was a definite disc and field loss there. So a regular NTG workup that consists of a cardiac evaluation with echo and carotid Doppler that was done was normal. And since he was a young patient, I also did certain things for ischemic factors like serum uric acid, homocysteine, vitamin D, and B12. Those were also pretty normal. So over next 1 year, on treatment, his pressures ranged from, say, 12 to 16 millimeters of mercury. Optic nerve looked more or less same. However, when we looked at the visual fields, particularly 10-2, this is the kind of progression that I saw. And that was quite alarming. If you look at the right eye, the 24-2 did not show as much change, only a couple of spots, but the 10-2 showed a significant progression. So I was worried what is happening. Now, this visit, the wife was accompanying him and she gave the history of snoring. So that was the part that we had not, that time he did not give a history of snoring. So I had not evaluated him for sleep apnea. But with this progression and the history of snoring, I suspected OSA as one of the possibilities. So he advised for the sleep study and physician's opinion for the same. So he did underwent a sleep study and to the surprise, he had a hypopnea index of 12.8 per hour and AHI of almost 33.2. So that is a quite a high hypoapnea index for a OSA. So definitely he was diagnosed to have a severe obstructive sleep apnea. And the AHI in REM sleep was almost 54.2 per hour, which is quite high. And when we looked at the oxygen desaturation, the lowest SpO2 was 81%, the highest being 94% during the sleep. So So the diagnosis shifted to associated with the sleep apnea, severe obstructive sleep apnea, and this is what his physician advised. So they started him on CPAP at night with the nasal mask. And so our treatment for glaucoma remained the same on latanoprost eye drops and advised to start CPAP along to prevent hypoxia. So this is over next 10 years. His follow-up has been, and he's been pretty stable. Yes, we did, this is the OCT, which is more or less similar. And we did add timolol at one point because I felt the pressures we needed to lower further. So he has been stable. So this case was just to highlight that this is one of the major risk factors for developing glaucoma and NTG also in young patients. There are studies that show the strong association between obstructive sleep apnea and glaucoma. And all OSA patients should actually undergo a complete ophthalmic evaluation to rule out glaucoma. Particularly patients with obesity and progressive visual field damage, even with normal pressure, should be evaluated for OSA. As I said, in this particular case, if I would have done OSA, the sleep apnea study earlier, we might have been able to pick up early. It delayed almost 1 year where he had the progression, and after that only I could look at that component because of lack of history. So a strong suspicion is definitely required in these situations. So OSA particularly has a significant effect on glaucoma, not only in terms of low IOP, but hypoxia is something that causes oxidative stress, and that further augments the RGC death. In addition to that, there are vascular factors, of course, due to autonomic dysfunction and vascular dysregulation. There is a compromised blood flow and perfusion that further adds on to it. And as such, the mechanical factors or obstruction increase the intraocular pressure also during the sleep. And also even the treatment like BiPAP also can increase the intraocular pressure. So OSA definitely has a significant effect on the outcomes in terms of RGC death and progression. So to summarize about the first case on OSA, the association between glaucoma and OSA is definitely established. However, temporality, dose response, and reversibility, as we have for intraocular pressure and glaucoma, is not as much. So looking at that, we definitely need to understand that it is important. It definitely has a role. So we definitely need to measure an apnea-hypopnea index in suspected patients with a history of snoring or where we are suspecting no other cause, and look at the sleep study. And also look at the oxygen saturation during the sleep, which can lead to hypoxia and the further damage. Treatment of OSA with more than 15 AHI is definitely indicated. Whether CPAP should be the ideal treatment because it can cause raised IOP or anything else is something that we should collaborate with physician for an appropriate modality of treatment for a given patient. Coming to the second case, now that is related to the defective autoregulation. This gentleman, 60-year-old, presented to me first in 2015. Visual acuity was quite okay and pressures were pretty normal, pachymetry being 504 and 524, and open angles. The CD ratio was 0.8 and 0.7. So we did have a suspicion. So we did a visual field, and visual field was normal. This is how his OCT looked like. So obviously we didn't treat him and kept him as a suspect and follow up. Again, he presented in 2017. At that time, this is how his optic nerve looked like. So there was a disc hemorrhage, which you can see there, is something that raised our suspicion. Intraocular pressure at this visit also was normal and the angles were open. Patient was not on any medication. And this is how his fields look like. You can see a small superior defect there. And the left eye was normal. When we did the OCT, there was a corresponding RNFL loss there where the disc hemorrhage was seen in the right eye. However, the left eye was normal. Since both clinically as well as visual fields OCT did show onset of glaucoma, particularly in the right eye, we did advise the full day diurnal variation of intraocular pressure. And as I said, as a routine, we do BP in all patients where we do intraocular pressure diurnal variation test. So if you look at the highest IOP in this patient was 18 or 19 here in the right eye and 18 in the left eye. But there was a significantly less diastolic blood pressure in the midnight. That is what brought our attention to the damage that he was developing. So this was the normal tension glaucoma with nocturnal drop in blood pressure. So he was started with the bimatoprost to reduce the intraocular pressure further. And along with the physician, we modified the dose of antihypertensives so as to reduce it to minimum for the night so that he doesn't develop the nocturnal dips in the blood pressure. He has been on follow-up since then and has been more or less stable. So the idea of this case to understand that how the blood pressure or perfusion pressure works. Well, optic nerve head circulation is segmental. We have a pre-laminar flow and the retrolaminar flow. And alterations in the blood flow that we visibly see may not reflect the blood flow in the deeper layers. So that is why it gets pretty hard to understand. So with the elevated IOP or without the elevated IOP, if there is a decreased perfusion pressure, there is a challenged autoregulation. And that causes an unstable ocular blood flow and ischemic insult to the optic nerve that further causes the RGC death or the optic nerve head damage in these patients. Well, Baltimore survey has clearly explained the association between diastolic perfusion pressure and glaucoma. And even EMGT has demonstrated that lower systolic perfusion pressure can lead to progression of glaucoma. And this particular physiological nocturnal dip may be exaggerated in patients who are using hypotensive drugs, and that may cause glaucoma progression despite of normal intraocular pressure. Whether there is the direct correlation of nocturnal dip with progression is yet to be established. And whether hypotension itself is leading to optic nerve ischemia, there is no direct evidence. However, there are studies which tell us that, as Dr. Ronnie was talking just before this case, that there are patients who are dippers and non-dippers based on the mean diastolic and systolic blood pressure fall in the night time. If it is more than 10%, they are called dippers, and if it is less than that, they're called non-dippers. So there is a strong association of these dippers along with the glaucoma damage or the progression. Epidemiological studies have also shown that low ocular perfusion pressure is a consistent risk factor. So, and it is associated with low blood pressure. So ocular blood flow itself has a mean arterial blood pressure minus IOP divided by vascular resistance. And that is where the diastolic blood pressure as well as systolic blood pressure play a role in optic nerve head perfusion. So systolic, diastolic, and the pulse pressure all are important. Autoregulation to maintain the blood flow is again important. There are mechanisms so that when there is vasoconstriction, ocular perfusion pressure is high. When there is vasodilation, it is low. But when there is defective autoregulation, even these compensatory mechanisms fail, and that is how the optic nerve head gets into ischemia or hypoxia and then causes the damage. A little about my own experience about nocturnal hypotension and the low normal tension glaucoma. We did an observational case cross-section study where patients with NTG on open angles were and full day DVT were taken into account. And these patients underwent intraocular pressure check and BP check every 3 hours. The IOP check was done by GAT, so that was in sitting position. So this is what we noticed, that among these 149 patients, the biphasic peak was clearly evident. And 40 patients among these were detected to have a peak IOP, which was more than 20. So those were labeled as POAG. So idea to tell that is that it is important to measure the intraocular pressure before we diagnose them as NTG, because some of them may actually qualify to POAG. If you look at the full day BP variations, 20% of the patients had a nocturnal dip in their blood pressure. If you look at this particular cohort. Even patients who had POAG in this group, 40 patients that I told you, 17% of those also had a nocturnal dip in diastolic BP. So the dip in diastolic BP is important for both NTG as well as open angle glaucoma patients. Further, when we look at the cardiac abnormalities, 8% had cardiac abnormalities which required intervention. Well, this study has been published in IJO. The idea to tell this is that measurement of BP as well as cardiac evaluation for ischemia is important for NTG patients. So to summarize, the nocturnal hypotension, again, we have an association of intraocular pressure with ischemia. However, the other things like dose response, reversibility, temporality is not yet established. But what we understand is that blood flow definitely has a role. We definitely need to do BP, ECG, and heart rate in patients with NTG, particularly with patients on beta blockers. We should understand what are the drugs they're using and the timings of their drugs so as to be able to understand how to manage that and be alert to subtle signs and symptoms. There are no therapeutic interventions directed at blood flow as yet, but I hope something that we can have in future so that can help these patients. Thank you for your kind attention.
So thank you, Sushma ma'am, for such a wonderful presentation and beautifully highlighting the importance of BP monitoring along with the diurnal variation test, because that solves the problem of waiting for the patient to progress and then we look for the BP. Instead, if we do the DVT altogether with BP, I think that will solve the problem. So with that, I would request Guru Satinder sir to give his opinion, since because the literature says, and as ma'am has also said, that the NTGs are associated with the dippers. They are kind of associated with the dippers and the non-dippers, and along with the OSA, possibility of OSA happening in these cases. So, sir, would you recommend a regular screening in your clinics for all the cases of NTG to undergo the OSA screening?
So first coming to the OSA screening, there's certain, indicators that patient may be having OSA, like patient is a habit of snoring is of course one thing you can have. And daytime sleeping, the patients having narcolepsy, having morning headaches and nocturnal oxygen, of course, desaturation is there in these cases. So high index of suspicion is required in these cases. As we all know that normal tension glaucoma is a diagnosis of excluent, because you can't label it as normal tension glaucoma unless you have excluded the neurological factors like like it was referred to the like carotid artery disease also, and of course hypertension, antihypertensives at night. So a lot of factors. But coming to obstructive sleep apnea, it basically leads to retina. It's a very active metabolic structure. It needs a lot of oxygen. So whenever this sleep apnea doesn't mean snoring, it means the patient stops breathing for some time. So when he's not breathing for that point of time, so what happens is the oxygen level in the blood goes low. That means oxygen saturation of the retina is decreased, which is a very active metabolically. So that probably leads to some sort of endothelial dysfunction, oxidative stress, and of course mitochondrial dysfunction, which probably leads to some cascade of apoptosis. So so this is probably the mechanism that has been said. So for these cases, the sleep studies, as Dr. Tejwani has rightly said and very elaborately talked about this disease. So in these cases, sleep studies, of course, required, which was done in these cases. And once you, and this patient is very young patient, and young patients, you don't expect normal tension glaucoma. Average age of a normal tension glaucoma would be something like 65 to 70. So young patient and with 30, 35 years age coming out of this. So you have to rule out any causes, anything to do with the pituitary, any other neurological cause. You have to rule out any other contributory reason for this. And sleep apnea, as she has rightly shown, is a very important cause. And of course, then you have to, these patients can be treated. You have to ask them to weight loss. Obese people are more likely to have sleep apnea. Then, of course, you have to ask them to avoid alcohol and sedatives. They also lead to sleep apnea. And smoking cessation also helps in these cases. Plus, of course, PAP therapy, as it was advised in this case, is important. And some cases may actually require, sort of some surgical intervention in the form of uvulopalato-pharyngoplasty, or some other intervention may be required in these cases. And some patients may have just allergies, even the nasal decongestion might help. So basically, you have to go to it has to be an approach which is multidisciplinary, and you have to find out the cause. Once you know it's a sleep apnea, then of course it needs the treatment. Like in this case, as Dr. Sushma has very nicely shown, the patient was stabilized over years of time and there's no further damage. So that is regarding the first case, that obstructive sleep apnea. And of course, the second case was a case which had hypertension. And of course, low, like it's sort of a low pressure at night. So as like it was early pointed out by in Shahinoor's case also, that I think Dr. Chandrima and Dr. Rani, they commented that blood pressure has to be monitored in these cases, nocturnal blood pressure. So if they have been, if there is a variation between daytime and nighttime, and the blood pressure is less than 10%, they are thought to be the normal. So 10 to 20% variation, we call them dippers, And if the variation is more than 20%, they are over dippers. So over dippers having a variation of more than 20% in the IOP at night, they are the ones who are likely to have glaucoma and probably diagnosed as low tension glaucoma. And so you can do ambulatory blood pressure monitoring in these cases in which patient measures the cuff all 24 hours of a day and blood pressure is monitored. He indulges in normal activity. He doesn't go for any excessive exercise or any kind of the like what caffeine and it's advised. Normal activity is done. Then you find what is happening to the blood pressure, whether he's on treatment or off treatment. He continues the same treatment what he's taking. So at the end of the day, you find whether he's a dipper or over dipping or so as Dr. Sushma has rightly pointed out, we have to modify the treatment regime in consultation with the treating physician. There is an interesting thing which was said, which has been postulated is a ischemic reperfusion injury, which has been postulated even in the cases of when you have like something like cardiac cases also following myocardial infarction or following the transplant of an organ. So they say when there's a reperfusion is there, it leads. So once if there is a low perfusion is there, then there is some oxidative stress is there. There's ATP depletion. There ionic pump failure is there, and of course, apotrotic pathways they get active. But once the IOP goes there's a reperfusion, that means that the blood pressure goes high and pulse pressure is more, or blood supply goes high, blood pressure rises. There's a reperfusion of there, and that leads to oxidative stress. And of course, endothelial injury and calcium influx again leads to injury. So it's a multifactorial thing which occurs with the perfusion. So this ischemic reperfusion injury has been postulated as the cause of, mainly the cause of this a nighttime dip in the blood pressures in these cases. So I think Dr. Tejwani has done a wonderful job in showcasing two wonderful cases. I congratulate her and I thank AIOS and of course for involvement, and Dr. Shweta for involving me in this program.
Thank you very much, sir, for the beautiful insights. And now I would request Manish, sir, to share his experience about putting these patients on BiPAP and CPAP therapies and how do they respond, sir? What is your clinical experience for the same?
So in the many patients which we have found are having sleep apnea, they may be normal tension. Some of them have frank open angle glaucoma also. And after doing a sleep apnea test and the reference to a physician, when we advise them that they need a BiPAP or a CPAP, whatever is advised, at least 1/3 of the patients are unable to take the treatment because they find it very, very inconvenient. So this is a practical problem. And sometimes you really tell them that you're losing your vision, you may develop other cardiac problems, you have to take this, but they still just can't do it. So this is quite a big hurdle. And in treating CPAP, in treating the sleep apnea. And some of the patients who, as we have seen in the cases described by Dr. Sushma, if you give the CPAP and then you stabilize the disease, wonderful. I have seen this happening even older individuals. Her patient was a younger fellow. And when they take the treatment, we have seen the good results. But I would go out and say again that it is not as easy as it sounds when in meetings like this to advise the treatment for sleep apnea. So I think, and the machines have also improved. The new masks are much lighter and much easier to use. So there is promising progress over there, but still it is not that easy. That is a real point I would like to make out. And one more point I would like to bring out is that, in patients who are dipping, especially the older individuals, you will find this happening. The typical body description is the thin, very thin person and looks absolutely fit. You would say, "Arey, wow, what a 70-year-old doesn't have a tummy or anything." These are the very guys who are going to be the dippers. And second thing is that, they avoid water or fluid intake in the later hours of the evening because they have some prostate problem and they find themselves getting up too many times to go to the loo and they avoid water, and that is responsible for the dips. So I have had patients and in consultation with the cardiologist also advise them to have more fluid intake in the evenings, go and make the trips to the loo to save their vision. So that is one additional point which has come out in practical daily life, which I would like to bring out.
Sir, and just one more thing. Would you, for your patients, you take the decisions of putting the patients on BiPAP or CPAP, or it's with the help of the sleep therapist? Because the CPAP, the literature says that it does increases the IOP at certain point of time. So how do you go about those cases, sir?
So the first thing is that we have to be practical. We are not experts in giving the therapy. So always, even the test is advised by the physician only. They have the contacts with these fellows who come home and wire up the patient and do the test. So it is, I don't directly order that, get the test done myself. It is always, and the report also is forwarded first to the physician. So the treatment is definitely in guidance with the physician. Now coming to the point about the mask and all raising of the intraocular pressure, very difficult to find out in which patient what is happening. So in practical, I am not going to go home and take the bedside eye pressures of these patients while the mask is on. Impractical totally. So I think let's go practically, treat the patient and see what happens. As Sushma has seen, follow up and do the perimetries and check what's going on. If things are not going as good as you thought they would, then we go reverse and start investigating what exactly is happening. Because these reports of the mask increasing, they are there, but equally number of reports are there in patients benefiting. So I am a little bit lost. So I would like to take the positive and keep the negative for the reserve.
Yes, sir. Thank you, sir. So Aji, sir, what is your take on that, sir?
No, I think I agree with Dr. Manish on this because ultimately CPAP or BiPAP is decided by your sleep specialist. They decide what is appropriate and how much pressure they need to keep the airways from collapsing. And most of the time, these patients are progressing in spite of good intraocular pressure control. So we have done our job. And whatever progression is happening now is because we suspect it's because of the hypoxia. So it's important that we correct the hypoxia, and whatever the sleep specialist suggests is fine. If they are progressing in spite of that, then maybe we could consider whether the pressures are spiking because of CPAP. But I actually personally haven't come across anybody who was on CPAP who continued to progress at a rate that I was uncomfortable.
Yes, sir. And so one more thing in the continuation of the same discussion, once the OSA is under control, do we need to titrate our own treatment with that, sir? Keeping the disease progression in mind, the disease has stopped, for an example, yes.
Yeah, it's a question of when you have picked it up. If by the time you have picked it up, the patient is on 5 medications and the pressures are still, you can then take a call and try and reduce it, provided you see stability over the next 2 fields or something.
Right, sir. And sir, what about the lifestyle modifications for the, as sir was very correctly pointing out, that to keep yourself hydrated, that's one of the most important thing to prevent those ONH perfusion getting hampered. So any more lifestyle modifications for these kind of patients, sir, would you suggest?
So I think these are the modifications that we all ask our patients. Do you drink large quantities of water at a time? Do you do the inverted headstand? How much of physical exercise do you do a day? Those type of modifications. I really don't advise them to do anything specifically beyond that.
Right, sir. Right, sir. Thank you very much, sir. With that, I again call upon my co-moderator, Mona ma'am, to moderate for the next case.
Thank you, Shweta. And I would like to now request Dr. Shifali to present her bouquet of cases to us.
Is it visible? One sec, share.
No, ma'am, I think your mail is visible. You might want.
And one sec.
So while ma'am is just getting ready with the presentation, I'd just like to ask everyone how easy it is to convince the patient to go and get a sleep study done, and how easy it is to like get it done near your center, or do you face any challenges in that? An open question.
Mona, is it good?
Yes, ma'am. You can go. Yes, ma'am. It's visible
Yeah,
now.
if you have a question for audience to continue, then I will take it up.
No,
Or shall I?
You can start. We'll take it up at the end together.
Okay. So I would like to thank AIOS and Shweta and Mona for giving me this opportunity. I'm going to talk NTG. Is it a spectrum of POAG or it is a group of heterogeneous diseases? As already a number of other speakers have mentioned it. So to start, non-IOP glaucoma is basically exception in the glaucoma family because the major risk factor, that is the raised ventricular pressure, is missing here. But still the disc and the visual field damage we continue to see, and they also progress. Number etiopathogenesis. Number of factors have been proposed, like genetic predisposition. There may be IOP dependent or IOP independent factors. Coming to the genetic predisposition, there is increased prevalence in Asian population compared to the Caucasian. That is what we see in normal tension glaucoma. In one of the prospective study in Zulu population in South Africa, it was observed that 57% had normal IOP in open angle glaucoma cases versus 30 to 39% in USA. So this demographic difference seems to point towards genetic component or maybe the variable susceptibility of optic nerve. Now, IOP, whether already we have discussed whether it is IOP dependent mechanism or IOP independent. So it is unstable. Okay. Audible?
Yeah, you are audible.
What we see is focal and deep defect fixation. And to
Dr. Shefali, you're muted.
Ma'am, you're muted.
How come it happened? Is it? So
now
right,
it's fine.
Is it okay?
Doctor, try again. The sharing has stopped.
You need to share.
You need to share again.
Screen, ma'am.
1 second. Here. This is gone. 1 sec. One, I think you can take up the another, then I will, I don't know what happened in between.
So now we can call some another speaker, she's saying.
Yeah.
Ma'am, yes, ma'am. No, ma'am. So that's what I'm saying. So if the time permits, maybe you can start presenting, or maybe I can start presenting, either of us. So maybe, ma'am, you can start share your screen and then you can present, ma'am.
You want me to present? 1 second. I'll share my screen.
Yes, ma'am.
See, I'm again sharing.
Okay, great, ma'am.
So were you able to, means I have to start from the beginning?
Once you share, we can just skip over the slides.
Yeah, can you, doctor, make it slideshow mode, please? Full screen.
Yeah, yeah. So you're seeing it?
Yes, perfectly.
So I think we were on this slide. Sorry for the delay. So as I already discussed that in collaborative normal tension glaucoma study also, despite bringing down the pressure 30% less.
Sorry to interrupt, doctor. Can you make it slideshow full screen mode, sir? Slideshare. Yeah, perfect. And then same button. Yes, yes.
Is it? Is it?
Yeah, perfect, doctor.
Yeah,
Please,
yeah.
doctor. Thank you.
So still in 12% of the patient, there was progression. So coming to the IOP independent mechanisms, already it has been discussed that there multiple mechanisms have been proposed, like maybe the optic nerve is more susceptible to the normal range of intraocular pressure also than regarding the vascular dysregulation. And because of the reduced ocular blood flow or fluctuation in the blood flow, there may be nocturnal dips, and it promotes the apoptosis of retinal ganglion cells and their axons. Similarly, there are other number of mechanisms, but still it is not well understood entity. Also, if you see the presence of the disc hemorrhage, already it has been discussed that they are more prevalent in normal tension glaucoma, and also the vasospastic diseases are also more common or associated more with the normal tension glaucoma. And in fact, collaborative normal tension glaucoma study have found out, or it is published, that the presence of disc hemorrhage and history of migraine is associated with the faster progression and visual field loss. So coming to the couple of cases, this is case 1 years old male with no systemic disease. And however, he had a subjective feeling of deterioration in vision. Both eyes had undergone cataract surgery in 17, vision was 6/9, open angle, anterior segment was more or less normal, corneal thickness was within normal range. And if you see IOP at first visit was 19 in right eye, and in left eye it is 21 millimeters of mercury. And IOP which were measured elsewhere till now, because this patient was referred to us, they were always below 18. So this was the disc. You can see the definitive notch, and you can see the fields which were present with the patient. You can see this VFI, it is definitely showing the round trend. So this patient was progressing. And we know that before diagnosing any patient as normal tension glaucoma, we always do DVT. And since this patient was progressing, so definitely we have to do DVT. So we confirmed this patient DVT, which for pressures are always between 14 to 18. And we look for the other factors like nocturnal hypotension. Here, this patient was not hypertensive to begin with, not on any antihypertensive medication. So we did not do that ambulatory blood pressure monitoring. We took other exhaustive workup was done. History was taken. No history of steroid use, no major history. CCT was normal, and sleep apnea, because we usually don't do to begin with. Usually with the patient, we take into account that stop bang that score. And if we think that yes, patient fits into that criteria, we do the sleep apnea. So in this patient, rather than this thing, we ask the other history also. Patient, only the positive history, that patient told that he was used to taking this, or he takes this alternative medicine of prescription of 1 liter of water in the morning. So we decided for doing the challenge test. We asked the patient to drink the amount of water that he takes early in the morning. So we called him in a OPD, and he drank 1.5 liter of water. And you can see the pressure, which was in right eye, immediately within within 15 minutes and half an hour after, and at 45 minutes also, this pressure was after half an hour, the pressure was 29 in the right eye, and left eye it was 31. So we started patient on the travoprost and beta blocker in both the eyes, because pressure was going very high. And we planned this target IOB to be low teens, because this patient was progressing very fast. So we know that the mechanism of IOP spike, due to water drinking, there is an increase in the choroidal perfusion, increase in the choroidal thickness and the volume, which leads to the increased peripheral vascular resistance, leading to the raised episcleral venous pressure, and ultimately obstructing the outflow facility. Also, another mechanism is because of the hypervolemia. It may be related to the changes in the blood osmolality. Coming to the case 2, 64 years female with family history of glaucoma. Mother was bilaterally blind, and the patient had typically complained of repeated headaches. Again, this patient was referred to us, and because of which these repeated headaches, patient had already undergone MRI, which was normal. It was done elsewhere, and patient was following up for glaucoma since 2015 elsewhere, and now the patient, because patient was progressing, patient was referred to us. Central CCT was normal, gonioscopy was open angle, and you can see this GPA where it showed the likely progression. This again fields were done elsewhere, and this is VFI. You can see it is definitely downward trend. This patient is progressing, and so as usual we did DVT in this patient. And you can see all the pressures, they were up to 9 to 13, and in the right eye and left eye 9 to 14. So all the pressures were absolutely low teens. Now this, we further evaluated the patient. Only the systemic history, patient was diabetic, which on treatment. However, patient complained of history of cold feet, and another history which was significant, what we thought was significant, of the repeated headache. Though the headache was not associated with the typical, that aura or the flashes, but still we considered, because the patient had cold feet and the history of headaches. So actually we referred this patient to the physician. Blood pressure was normal, and we ruled out the other causes of the vascular or autoimmune diseases and the inflammatory diseases by doing CBC, ANS, CRP, and ESR, which were normal. So actually we thought that here, because we thought vascular dysregulation may be contributing to the progression, we referred this patient to physician, and patient was started on amlodipine, which is calcium channel blocker, and already now we are following up this patient for last 2 years, and since then patient is stable, but still we are following up this patient every 4 monthly, and if the progression occurs, we are planning to work up for sleep apnea and maybe carotid Doppler. Case 3, 61 years old male, presented in 2020 with complaint of dimness of vision for distance. He is again a non-glaucoma suspect patient. Pressures were 16 and 17 according to old records, and patient was on dozolomide timolol combination, and patient did not have any systemic disease, and he was undergoing to physician regularly. Where anterior segment, if you see normal vision, normal open angles, and pressures were 13 to 16 and 14 to 16, and the CCT was within normal range. You can see here the GPA, the patient was showing likely progression. So this is actually Rajul's patient. So because patient was very concerned and he was showing progression, again we did here DVT also, but on asking again and again, he said that he is doing the Shirshasana daily for at least 15 minutes for last 9 to 10 years. And Rajul measured his IOP, and the pressures in that posture, pressure was 34 and 31. And already it has been documented that because of the, when you in the head down position, there is a raised episcleral venous pressure, which is due to the elevation in the thoracic venous pressure that is transmitted through the jugular veins to the episcleral venous. Episcleral venous pressure may increase, and leading to the resistance to the aqueous humor outflow. Other factor may be compressive forces placed upon the globe by congested orbital contents and the increase in ocular blood volume with congestion of the uvea, which may also contribute to the raised IOP. So here we advise the patient to avoid Shirshasana, and of course where breath holding exercise, where you have to hold the breath, which mimics the Valsalva maneuver, that also we asked him because patient was progressing. And this is just 1 year we are following up the patient still, and we have still to do another visual field in this patient. Now coming to the case 4, 62-year-old female, history of thyroid, second opinion for suspected normal tension glaucoma. Pressures were 15 and 18, and the DVT which was done, which is within normal limits. CCT was again 534. In both the eyes, and if you can see, the disc is 0.6 with inferior rim is equal to superior rim, and left eye was 0.85 CDR with inferior notch. So we started this patient on travoprost because there was notch. Now, the right eye fields was absolutely normal. We are following up this patient since 2021. You can see this is left eye visual fields and the 10-2 because they are near the fixation. We did the 10-2 and you can see this pattern. OCT was correlating in the left eye. So we are doing the fields continuously, and we know in advanced damage, mean deviation is a very good marker to look for the change. Though we have only 4 fields, but because of the forum we have, we could see the trend in the MD this thing that there is a downtrend. That means patient was still progressing. We again did the DVT in this patient. All the pressures were less than 12 on treatment, and still the patient was continuously progressing. And even after repeating DVT, the pressures were within 12 to 13 millimeters of mercury in both the eyes. There was again no history of snoring, water drinking, steroid use. We asked all these things, and while going through the literature, then we came, and only other significant thing in this patient was that patient has a hyperthyroid, and second patient had very low weight. The patient weight was only 30 kg. So we actually with this on Google we calculated the this body mass index of the patient, which was only 16, and you can see the normal BMI is actually between 18.5 to 25. Depending on the age, you have to put all the values in the calculator and you come to know what is the BMI of the patient. And if you see the literature, there is definitely association between the body mass index and the POAG. And even when the normal tension, when the pressures are normal, low BMI was associated with the greater risk of glaucoma diagnosis and also with the vertical CDR ratio. So in this patient, we referred for physician checkup, for the nutritional supplements also, because the patient's hemoglobin had dropped down to 6, and to optimize her thyroid control, and also to have proper diet so that she can gain the weight. So to conclude, NTG is a complex syndrome consisting of a variety of pathological pathways that may differ between populations and individuals. Always rule out IOP dependency, as it is a modifier risk factor, and number of times when you do DVT and if you do proper workup, patient may turn out to be actually high tension glaucoma. Always rule out whether this NTG is progressive or non-progressive, because we have to monitor this patient and do the follow-ups depending on whether the patient is progressive. A non-progressive may be a little bit lenient, but if the patient is progressive, definitely we have to follow up more aggressively, and sometimes even lifestyle modification may help. And detailed history may help to pinpoint the etiopathogenesis of optic nerve damage. So my question to the panel here is, so in these 2 cases where post-water drinking and Shirsasan, would you classify this as a normal tension glaucoma or open angle glaucoma? Because most of the time we don't do, or we don't ask this type of history, and we do not check after water drinking whether the pressures are increasing or not. So most of the time we miss, but should you label this patient as a normal tension glaucoma or open angle glaucoma? And second, would you recommend carotid Doppler in all patients of normal tension glaucoma with suspected vascular dysregulation? Thank you. Sorry for the delay. I don't know how it happened.
That's a part of the online thing. Don't worry about it, ma'am. So it's a very
I'm stopping.
area of
I will
cases.
stop sharing. Yeah.
Okay, it's a very interesting area of cases. So I just want to ask Dr. Chandrama ma'am, when you see patients progressing so fast at such low pressures, apart from getting sleepless nights, what else would you do?
Yeah, I think she's basically done everything. But answering to the questions that Shafali asked are, number one is the water drinking patient. The water drinking patient, well, in our student days or in our MBBS days, we regularly did the water drinking test as a provocative test. It's no longer carried out because it can precipitate an attack. But then I think that's a test where, you are almost sure that there's something going on if the provocative test is positive. So that's one. B is the Shirsasan part of it. Like, we have evidence in literature about it. We have the Hamilton Sleep Laboratory where they had done IOP measurements with different types of exercises. Like they concluded that cycling actually brings down IOP, whereas resistant exercises make the IOP go up. And we have our very own Dr. Tanuj Dada and the AIMS people who have done the study saying that Shirsasan and I think Matsasana, these are the two exercises which actually increase the IOP. So yes, I suppose when you find no other reason why it's progressing, you need to basically ask the patient in detail about all these things. And carotid Doppler, I feel that if there is a asymmetry between the two, then I think carotid Doppler is like definitely indicated. But if both are progressing equally, I don't think carotid Doppler really has very much to do in that, basically.
Yeah. So yeah, thank you for your comments, ma'am. So the water drinking test, would you do empty stomach or would you do it at any time if they are asking them to fast for about an hour or so? How would you do that water drinking test currently if you have to do it as a provocative test?
Yeah, as a provocative test, basically, what I remember of our MBBS days is that we would do it anytime because in the medical college, there was too much of rush to ask the patient to wait for half an hour or things like that. But ideally, yes, you should ask the patient to wait for half an hour and then ask the patient to drink the water and then do it. But if you have a very busy OPD, then it's a little difficult.
So what advice do you give to the patients when you see there's a spike after the 15 minutes after drinking a 1 liter of water of more than 500 ml? So is it just for water or you advise for other liquids also?
Yeah, so we would talk to the patient in detail, like what's actually going on, try to explain to the patient that this is what is actually increasing your intraocular pressure and any kind of liquid actually for that matter. Of course, we don't generally drink 1 or 1.5 liters of anything else apart from water, but then you have to, tell the patient that this is actually what can happen if you are drinking anything in a liquid form to that extent that your intraocular pressure can go up, basically.
In this, we didn't do this as a provocative test. Actually, we did this as a challenge test to diagnose whether our patient. Patient gave
yeah, I saw that. You all did it as a challenge test because he said that he would drink water. But what I said is that way back, say 20, 25 years back, we would do it in the medical college as a provocative test.
Yes.
Because at that time, we didn't have the OCT and we didn't have all the other sophisticated tests. So this was one test and the other one was the darkroom test, which we would do as provocative test, to diagnose glaucoma, basically. So.
In its second innings, the water drinking test is a very valid test as a test of the outflow facility. And it gives you a very clear indication of the peak IOPs that you're going to get at night. It also gives you a very, very clear indication of the IOP fluctuation in your patient. So even though it is no longer considered as a diagnostic test for glaucoma, like ma'am mentioned, the provocative test, it is definitely has a place in current glaucoma practice, which tells you about the peak IOPs. If you're not doing a pressure at night, then this is a very, very good surrogate. I know Dr. Rani George is going to say no, but glaucoma specialists aren't supposed to agree with each other. And the prescribed way of doing it is 2 hours of water fasting, a 2-hour water fast before, and then you do a 10 ml per kg body weight of water challenge. And it's a very valid test, and I do it for almost all of my patients of glaucoma before I start treatment and thereafter once they are on treatment. And I do it in clinical practice, even though I do it on the NCT and don't applanate every 15 minutes, because what I'm looking for is the fluctuation on the same machine, same operator, before and after. So I'm not using it as a number on which I'm treating the patient, but seeing what the fluctuation is like.
Did you compare NCT and applanation readings?
No, that's a different debate. Glaucoma practice is based on applanation tonometry, but for a water drinking challenge test, you can use it only as an index of fluctuation. So don't say it went up to 31 millimeters of mercury, but you say that the fluctuation was 8 millimeters of mercury. So that's something that remains valid, because to applanate every 15 minutes, same machine, same operator, is very tough in a busy OPD. So this is like a cheat sheet on it.
More than 7 to 8 inter-eye or maybe within the same eye also fluctuation. Yes, going 6. Up is a definitive.
6 is bad enough.
But I would like to know whether as for a diagnosis, like what you are telling, so what are the other panel's opinion regarding this thing? Doing water drinking as a provocative test.
See, we actually published a study on the water drinking test where we did it formally, because we did have a few patients where we thought that the peak, that it was explanatory in the sense that we were progressing in spite of good intraocular pressures. We do the water drinking, the spike like anything. But we didn't actually find a clear association with the peak IOP. We found a correlation, but not a clear association. But having said that, if you have a patient who's progressing in spite of everything, there's nothing wrong in trying a water drinking test, because that might give you the answer, and it might sort of show you a fluctuation, a potential fluctuation that's going on. So I'm not saying that you don't do it in everybody, but across the board, I don't think we found it to be particularly useful. And we did check IOPs with appellation every 15 minutes. Same machine, same observer.
And since you also please also share your experience regarding the Shirshasana study and the other exercises, isometric and other exercises.
Yeah, so with the Shirshasana study, actually it was first done by Dr. Bhaskar at Shankaretralaya almost 20 years back. And when they did it with trained yoga instructors, they found that the intraocular pressure doubles during the asana. It comes back to normal within about 10 minutes. But during that period, it does double. So that was the first sort of publication that showed that Shirshasana is a cause for concern. And generally, any asana where the head position is dependent for some time is going to be a problem, because the column of blood, increase in venous resistance is what causes the pressures to go up. Then you have some data to share on other forms of yoga, Mona. So why don't you give your experience?
Yeah, it's a small study where we looked at Kapalbhati, where we found that after 5 minutes, the IOP goes up in POAG patients and also in normal patients, more in POAG, but then it comes down by 15 minutes. But it does rise by at least more than 20-25%. So same issue as breath holding or the Valsalva maneuver, where it increases the episcleral venous pressure. So coming down to BMI now this is very interesting, because in NTG, most of the studies have associated with lower BMI, whereas if you have high BMI, you'll have sleep apnea and you'll be on the other side. So which way to go as far as BMI is concerned? And with a very low BMI, like in ma'am's case, would you go in for a full nutritional profile? And because with such a low BMI, there would be other deficiencies also. So which one is responsible for the changes in such a case?
No, it's very difficult to pinpoint which exactly, but I definitely feel a hemoglobin of 6 definitely means reduced oxygen carrying capacity of the blood. So you have everything from hypoxia to probably all sorts of nutritional abnormalities, which are all contributory. And you could very well be in borderline failure, which itself is another sort of risk factor for all this. So somebody with a BMI of 16 definitely needs to be completely assessed to see what's going on.
Also, there is a definite linear and positive correlation between BMI and CSF pressure. So that's also something we would like to keep in mind, because this must also be low perfusion because of decreased CSF pressure. 16 is somebody who's unhealthy. I mean, it's size 000, I think.
And interestingly, actually, you also notice low BMI in patients with pseudoexfoliation. So it's just one of those incidental findings that has been replicated, and we noticed it first. It was again replicated by a couple of other studies. So that's interesting. I don't know why, but it's there.
So the BMI usually has a U-shaped pattern in terms of correlation with normal tension glaucoma. 25 to 30 is actually protective, which is really strange, because you would also look at it in terms of allostatic load, because you're now bordering on obesity. OSA acts on it, but also you would also need to consider the allostatic load of any metabolic syndrome, which has the same underpinnings as the pathophysiology of glaucoma. So it's like a tightrope walk, I think. I mean, 16 is a non-negotiable, but do you ask patients to put on weight if they are at a 18.5 or a 19?
I think their patient, basically, you need to assess.
Yeah, this one's
and see, a lot of the U-shaped curve is because you have a lot of East Asian people in these studies. And generally, the Japanese and the Koreans are on the lower end of the BMI as compared to the
rest of us.
So that was a very interesting discussion, and we'll move on to the next case now.
So I would request Mona ma'am to share your screen, ma'am, so that we can start your presentation.
So it's a short case on NTG myopia and more. Let's see what additional risk factors I can put on the table after a great discussion up till now. So this was a 47-year-old female who came for a routine checkup for glaucoma evaluation because her father had a history of glaucoma. She is a high myope and no other significant history was there, and no risk factor at that time for the NTG as we have discussed till now. Slit lamp examination was basically she had a vision of 6 by 7.5 and 6 by 18 because of the cataract which she had in both the eyes. Other than that, the angles were open and there was no pigmentation on the cornea, and the pachymetry was also normal. IOP in the morning around 10:30 was 18 and 20 millimeter of mercury. So this was her discs. If you can see here, it's tilted, myopic, slight sloping here, little less rim here, and parapapillary atrophy. And in the left eye also similar kind of a picture. So this is the red free also. And these were her fields. If you see in the right eye, some paracentral defects have started, and the left eye shows infero-nasal field defect there. The field is fairly reliable, although even there's a little movement on the gaze tracker. So at that point of time, we also did the right eye 10-2, which showed again a paracentral defect here. So so just to show the discs, it was not a very great correlation, structure function, but then this was the field which was around done 11 years back elsewhere. At that point of time, her baseline IOP was 16, both eyes, and the right eye was fairly okay. The left eye had the infero-nasal defect, but of course it was smaller, so it had progressed. So although there was a correlation, but wasn't very great for the structure function, she went for a neurophthal evaluation also, but nothing significant was seen. She basically was planned for cataract surgery, both eyes. So because of the risk factors, she was put on timolol, both eyes, and underwent cataract surgery. And the timolol was continued after the cataract surgery as well. And her axial length was almost 28, both eyes. So this was during the pandemic time. So there was a little gap between the right and the left eye surgery owing to the pandemic, during which time she continued the timolol. And post cataract surgery, the vision was 6, 6, and 6, and pressures were 16. And follow-up was not very great, but she kept coming for follow-up. And this was post cataract surgery. You can see the right eye, not much progression, only 2 points, but the left eye, there are, you can see some areas which are showing progression. And here the issue was that the baseline was pre-cataract surgery, but then we didn't have any other option that time. And this is the GPA again. So, sorry, showing in detail. So the next follow-up was again 17 months post-surgery. She was planned to switch, so that we'll switch her to the PG analogs, but then she came after 17 months. And again, we see some points showing progression. So PG analogs were added and the timolol was not switched, mainly because it was uncertain when she could come for follow-up. She was from a different city. She could be prostaglandin analog non-responder like we saw in the earlier case. And she also had non-availability of some medications locally owing to the pandemic. And later on, we planned to switch the timolol later. So with latanoprost and timolol, the pressures remained 13 and 14. And after that, this was her disc. And we also did a OCT just to see how the RNFL was. And you can see the diffuse thinning here. Of course, the axial length is 28 almost. And then this was her final field when she came a couple of months back. Again, some points paracentral were showing progression. If you see, the last field also is showing progression even in the trend. in the right eye. And this was the actual field, which was in March. And even the left eye 10-2 now is, we didn't do it earlier because it was an inferior nasal defect, but then because of the suspicion of progression, we did it in the left eye also, and there is a defect there itself. So this was the visual field 11 years back. So we visit the history again: high myope, high axial length, family history of glaucoma, all are risk factors which we cannot change. And there are studies which have shown that these patients are more at risk. These are the additional factors. When we revisited the history, during this time, what had happened, what she had history of episodes of low blood pressure and hypertension, used to carry salt along with her. She had episodes of, she had a time when vitamin B12 and D deficiency was there, for which she underwent treatment. She also had anemia and menorrhagia and was perimenopausal, and was using levonorgestrel. So, although she did not fit into Flammer syndrome, but she definitely had a low BMI, like we have described. She was tall and thin and lanky, and also had hypertension, not the other features of Flammer's. And we know that it is very difficult to differentiate myopia and glaucoma, but this patient did show progression. So this is the final 10-2 field. So what are the next steps to preserve her field and vision? She is an author by profession, so into leading, and her the defects are very close to the center. So should a sleep study be done? And what about the role of low estrogens at this point, and any supplements or any hormones? These are my questions to the panel.
Thank you, Mona ma'am. So I would be again requesting Subhashini ma'am to give her the inputs about, first of all, the 24-hour BP monitoring and how do we go about with the sleep study. Ma'am, can you please share this slide again, once again, where the questions are there, ma'am?
Thanks, Shweta. Dr. Mona, that was a very nice presentation, documentation of all the findings. And in retrospect, you went back and looked for the other risk factors. So as such, a normal tension glaucoma diagnosing is very difficult, and that with myopia, so we need, it's more challenging. So myopia as such, it's quite a difficult um, condition when you have to follow up the glaucoma. It becomes very challenging because of the optic disc structural change, the tilted disc, and then the torsional change with the peripapillary atrophy. So luckily in this case, we did not see much of only the temporal crescent was there, not very severe. So if I could know what was the degree of myopia, it was
mine
Dr.
almost
Mona,
minus -8 almost. It was a high
-8. Okay. Okay, but luckily there were not much changes that would affect the fields or the OCT. So in this case, we just treat it like any other risk factor. Myopia is a risk factor for NTG, and look for other factors also. Here in this case, generally in NTG, we need to ask for a history of acute blood loss. In this case, there has been menorrhagia, but generally it could be any RTA, road traffic accident, that could have caused sudden, the excessive blood loss, and that could result in that hyperperfusion of the optic nerve. So here in this case, it's menorrhagia, whereas whether this is a factor for worsening of the glaucoma, so I'm not very sure. 24-hour blood pressure monitoring would be helpful in this case. Monitoring will at least help us to detect if there is a dipping hypertensive on treatment, or
no, she's not
I
hypertensive.
missed that.
That's her normal. Normally, she has.
Dr. Mona, is this patient not a hypertensive?
No, not unhappy. Her BP remains low.
Okay, so
Hypertension
I
like
think we need
tremors.
to consider all other factors. Her blood pressure was on the lower side. It was more of, yeah, hypotension. So nocturnal hypotension, just like hypertension, is a risk factor for normal tension glaucoma. So we need to look for this dipping, so which we can do by this ambulatory blood pressure monitoring for 24 hours. So this will help us detect any changes, and we know if anything can be done if during follow-up there is a progression of the glaucoma. Carotid Doppler, I don't think is needed, and a sleep study, unless you suspect
She didn't give a history
case
suggesting
anything,
that,
because we
but just to
have the
rule
risk
out.
factor myopia. So, yeah, maybe it's a good thing to look for other risk factors, but sleep study, unless there is a history of snoring, then you can go for a sleep study. Role of medications decreasing episcleral venous pressure. I'm not too sure. I would like the other panelists to pitch in. Hormonal and vitamins, because this patient has anemia, so that should be taken care of. And menorrhagia also, if it's the menorrhagia which is leading to the anemia, so the anemia has to be sorted out, because these itself can worsen the worsen or help worsen the condition as such, the normal tension
She's
glaucoma.
taking treatment for that in the form of the levonorgestrel, which is kind of controlling the
Okay.
menorrhagia, and thus anemia is also
Yes,
being.
and I think all the other factors have to be taken care of, and so as to just stabilize the glaucoma. But otherwise, myopia, given the fact that monitoring is very difficult, especially in the high myopia, because the um, changes, the peripapillary atrophy, which happens, that itself causes a RNFL thinning. So, and hence it's very difficult to find out whether this RNFL thinning is because of the glaucoma, or it's because of the peripapillary atrophy. So it's just that serial um, field examination would just help us to find out any new changes, which any new scotomas which appears. If it is due to the, then you can be very sure that it is due to the glaucoma. And with OCT, again, it's a problem, because the peripapillary changes as well as, and yeah, in such a situation, you can actually go for the macular thickness. So what I would suggest, Dr. Mona, here, a macular thickness would have been helpful, or a GCIPL.
We've
So
done
that would have
GCIPL.
helped in monitoring the.
Yeah, I have done those, but
Okay. So what I saw, I thought was only the
it
RNFL.
was very thin.
Okay, yeah, here.
Would almost a floor would be reached.
Yes. So just the especially in high myopic patients, the macular GCIPL, or the macular thickness, would actually help in following up such cases.
Right, ma'am. So with that, ma'am, I would request Guru Satinder sir, sir, what is your experience regarding the nutritional supplements in these kind of cases? As in this case also, and in the other cases of NTG, what is your experience for the nutritional supplements or the dietary intake?
So I think a nutrition, like when the patient is anemic and having vitamin 12 and vitamin D deficiency, we know that vitamin 12 deficiency does impact the optic nerve. And anemia also, as Dr. Ronnie has already pointed out, can lead to decreased blood supply to the retina, and lead to damage. But generally, if I want to comment on this case, basically the thing is, I think the clinical examination of the optic disc, that is the most important thing. I am very big fan of serial stereoscopic disc photographs, which gives a good insight into what's happening, structural change. And of course, then as Dr. Swasni has rightly pointed out, the RGC analysis is probably more accurate in following up the case as compared to the visual fields, because visual fields can be erroneous in these cases because of peripapillary atrophy and different kind of optic nerve configuration. So, and I don't have much experience actually with the vitamins as far as the vitamins concerned.
Right, sir.
But then there are diagnostic challenges like RNF analysis, tilted disc, visual field effects, which may not be actually glaucomatous. And of course, then altered blood flow, impaired autoregulation. So many factors are there in these cases. But I think Dr. Subhasini has nicely covered everything.
Right, sir. Aji sir, a question for you. Like in high myopic eyes, it is said that usually in glaucoma, the macular bundle is retained till last. But in high myopics, it is said that they are more susceptible towards the changes in the initial phases only. So how do we discriminate or differentiate that this is because of the glaucoma or because the myopia-induced changes? So that's a common dilemmatic situation.
So that's $1 million question. Shweta, I don't think I know the answer. I don't think anybody knows the answer. Don't forget that because of axial elongation, you do get macular thinning. How much of it is because of the myopia and how much of it is because of the glaucoma is difficult to say. Even if you look at the JCC IPL, that for this patient, you can actually see a diffuse thinning and you can also see some sort of a temporal raphe sign in one of the eyes. So definitely both are contributory. And these are the difficult eyes to do. Mona's patient, if you look at this, the patient 11 years back, when she was whatever 37 years old, you can still see an inferior defect in the left eye. So that I would think is not really related to any pressure-related issue, but probably just related to the optic disc morphology or the retinal changes. Whatever little change you have seen after that in the left eye is not very much. The change is more in the right eye where the defects are central, which disappeared after the cataract surgery and came back. So again, but that's something that is probably something that needs to be looked at more carefully. And I agree with Dr. Gursachinder that, getting serial disc photographs, good quality disc photographs on them is a good idea. It's also challenging to take these pictures in myopes because you typically don't get very sharp focuses. The discs are pretty small. That's a bit unusual for a myope. So essentially in myopia, because you have so much variability in the structural features that you're finding, the best thing is to document with as many modalities as possible and try and get your pressures as low as possible. Here, again, I'm not very convinced that this is pure NTG because your baseline pressures were 20 with a PACLI which is about 540. So it's possible that on a DVT you would get few recordings which are, in POG territory.
Just one comment I want to make is that in NTG cases, like especially, because there is an inferior thinning. And if you look at the configuration of the papillomacular bundle, these fibers, arcuate fibers, the lower arcuate fibers, they go very close to the macular area. So that is why you have normally very dense central scotomas in normal tension glaucoma. If they're defected is at the upper pole of the disc, then probably you wouldn't get the central scotomas because the arcuate fibers from the superior pole, they curve around the macular area, whereas the lower fibers, they're very close to the fovea. So if you have inferior notch, it's more likely to have central dense scotomas and involvement of the central vision early. So I don't know whether it's a macular bundle thing, I'm not sure.
Right, sir. So with that, we come to the end of this case discussion. And Mona ma'am, over to you.
So I think I'll ask now Shweta to present the final case.
So since the majority of the work has been made easy by my people who have presented before me, so I would be rushing through cases. One I have picked up from my I can say my bank from my PG fellowship days. So this is the first case where this was a 41-year-old lady who presented with us with a simple examination for eye examination. And the past medical history was only that she was using some kind of oil for nasal polyps and itching of the eyes. And there was no history of diabetes and hypertension. But yes, she said that she had a history of low BP for 10 years, for which she was not doing anything. All the past history was not significant and the visual acuity was 6.6 in both the eyes. Anterior segment was well within normal limits and and so was the gonioscopy, open angle in both the eyes. GAT applanation tonometry showed 13 millimeters in the right eye and the left eye. It was 12 millimeters of mercury, and the fundus showed right eye inferior notching with 0.75 cup disc ratio with the inferior wedge NFLD, and so was in the left eye. So these were the fundus features of this particular case, and pachymetry was 555 in right eye and 553 in the left eye. These were the field defects, or I can say the fields of this patient, the right eye and the left eye. And since I said that it is from my fellowship days, so those days we used to do GDX. So as we can see that in the right eye, there was some depressed point in the right eye which had appeared in this case. So the structural changes were also there. So because the treatment is always a dilemma in the cases of normal tension glaucoma, and they are very slow progresses, so we decided to keep the case on a follow-up, not to put her on any kind of treatment. So this was a diurnal fluctuation. It was not fluctuating a lot also. So the patient was kept on close observation and was called 1 month later. And 1 month later, when she presented back to us, this time the pressure was again 12 and 10 millimeters, and the right eye field showed the progression. Now, again, GDX also showed some changes which had further progressed. And on repeat field, just to say that it was real progression, it showed that again there was superior arcuate defect in the right eye. So she was put on medication with the PG analog in the right eye, and she was reviewed 1 week later and was left on a single digit number of IOP. That was 6 millimeters in the right eye, and in the left eye it was 10 millimeters of mercury. She was sent off and asked for review. She came back again after 6 months, and right now, when she presented to us at that point, the pressures were 9 millimeters in the right eye, again the single digit, and the left eye it was 10 millimeters of mercury. These were the fundus finding, and as we can see that there was an appearance of a Drans hemorrhage in the right eye. So now again, the cupping had not increased, but there was an appearance of the Drans hemorrhage in the inferior temporal quadrant. On asking, she was little non-compliant towards the treatment, but the fields were quite stable. But again, structurally, as we can see, that the GDX, again, we could see that there was some superior depressed point as well. So now the case, these are the consequent findings of the right eye of the fundus field. These are the left eye, and this is the GDX finding for these all the 3 visits when we examined the case. So her BP monitoring showed that 110/80 was the BP, and the patient was called for review after 4 months. And taking same situation of the treatment dilemma and keeping that in mind, again a 47-year-old male who came to us with simple examination of the eye, though he had a history past which had injury to the left eye during a boxing match, but otherwise no history was significant. On examination, the this GAT was 14 millimeters in the right eye, and the left eye it was 15 millimeters. And gonioscopically, left eye didn't show any sign of angle recession. It was open, and these were the fundus findings and the corresponding field effects. Now, the pachymetry in this particular case was on the lower side, that's 490 and 495. DVT showed the fluctuation ranging from 12 to 15 millimeters of mercury. So my question would be how to proceed. So keeping that, again, the slow progressive nature of the disease, we took the history back again for this case, and now he revealed a significant history of water drinking in the morning and Shishasana history in the daytime. The significant negative history was ruled out in the form of no history of head injury, blood loss, or any kind of a steroid intake in form. And as already discussed, the water drinking and IOP does show a correlation, show the Shishasana. So now this case was kept on treatment by metoprost and advised the lifestyle modification of reducing the water drinking and to avoid the Shishasana. My question to the panel would be that the discussion further continues to treat or to observe, because when we look at the study done by CNTGS, it says that the 65 showed no progression, while 12% they did show the progression in the treated group. So how do we proceed about it further? So my point of putting across these two cases would be that the take home message should be clear, that what are the red flag signs where we should keep in mind that whether, even despite keeping the fact that the NTG patients are slow progressor, but still there are certain points if we can make clear, so the audience can take home message clearly that when to start treatment and when to observe these cases closely. So thank you very much. And with that, I would like to thank you everybody and acknowledge all my mentors from Shankar Nethralaya, having helping me in my fellowship days to put forward these two cases. Thank you very much. Ma'am, you're muted. Ma'am, you are muted.
Yeah, thank you, Shweta, for the lovely cases. So I would request Dr. Manish to comment on the cases with comments.
Both these cases are very typical, and as Shweta has brought out, the important points are what are the red flags, which are the patients which we should treat, and which are the patients we can get away with just observation, seeing that the progression is going to be slow and many patients are not going to progress. So I would give a lot of importance to the location of the visual field defects, and the closer they are to fixation, likely they are to affect the quality of vision. And those are the patients, that is one important red flag which I would not like to ignore. The second point is the patients who have thin corneas, and there are many studies showing higher progression rates in thinner cornea patients. So that is a second red flag. The third red flag is, as so many presenters showed, the appearance of the disc hemorrhage as a very important marker of vascular dysregulation, and which is going to contribute to progression. So during your observation period, as Dr. Gursatinder also pointed out, if you're taking photographs regularly of these patients, you will pick up any disc hemorrhages, and that would be important. The fourth red flag would be patients who are not likely to follow up very regularly. This is a very important, because we are very happy when we have a series of visual fields, especially if they are all done at our own center and we are able to use the software for progression. But in the real world, a lot of patients don't follow up regularly, and if they do, they follow up and get a field done on a different machine, sometimes a different brand. It's very, very difficult to compare. And these are the patients where we would not like to have them lose their vision gradually. So I would definitely err on greater treatment. So definitely normal tension glaucoma patients would require treatment, and these are the signs, these are the red flags which I would generally follow. And there are many other factors, as we have discussed, the nutrition, as well as the sleep apnea, as well as the low blood pressure dippers, and lifestyle habits of water drinking and Shirsasana, and so many other, even like wind blowing instruments users. We have not discussed that, but those are another risk category which is there in literature, and occasionally we do find patients who are doing that kind of thing. So these are points to keep in mind, and others would also like to add, I suppose.
Dr. Chandrama, I would like to ask you if you want to add to that, and also to comment that when you have such low pressures and still progression, how do you modify your trab? Like, do you do special modifications when you're doing trabeculectomy in these patients? You're muted, ma'am. Ma'am, you're muted.
Yes, sorry. So I think Manish has very well covered up everything worth saying about the red flags. And another thing to add to the red flags is a lot of people now do those dumbbell exercises, aerobic exercises where they lift weights, resistance. So that I think can be added to the long list of everything that Manish said. So that is it basically. And for treating the patient, well, number one, I'd say that you need to explain to the patient that get rid of your provocative lifestyle. What are the provocative lifestyles, which like Sirsasan, Shweta mentioned, and water drinking, hot water drinking. So those two things can be explained to the patient and got rid of. And apart from that, doing a trab on pressures which are not very low, or not very high, but the patient is progressing is definitely a big catchword. So there, actually, I would definitely want to modify my trab. I definitely go for releasable sutures number one, so that I can tighten the IOP post-operatively. And apart from that, what else? That's it, I think, about the trab. And of course, you would be using a mitomycin C, so that also needs to be monitored, whether you use it for a minute or 2 minutes. That's also important. And that is it. And I think the patient definitely needs a good chair time to explain all the lifestyle things which the patient actually needs to take care of throughout. That's it.
Would ask Dr. Ronnie to give the final comments for this case.
Okay, thank you, Mona. And I think thank all the speakers too. It was actually a very interesting session because you saw the entire spectrum of NPG, from the low IOPs to the borderline IOPs. And I think what came out of this is that the importance of a very good clinical examination. When you established what sort of intraocular pressure range the patient has, the importance of a DVT, the importance of asking for a history of suggestive of sleep apnea or nocturnal hypotension, of getting a good clinical evaluation done in terms of their blood pressures and other things. And also keeping in mind, that this is probably a condition where they're more likely to have systemic factors, whether it is a carotid issue, whether it is a nocturnal hypotension or a cardiac issue. And these should be looked at, especially in patients who are progressing without good reason. It's also important to remember that when you have somebody who is early in disease and you're not having defects close to fixation, you can probably watch them closely. If you have somebody with more close to central defects or much more aggressive disease, it's safer not to watch and rather to treat. Both groups of patients will require close follow-ups, especially soon after diagnosis, so you can pick up whether they are actually rapid progressors or not. Asking good questions about their lifestyle is also important. And again, what's really important here is a high index of suspicion, that I'm not relying only on the intraocular pressure to make a diagnosis. It's really, really important here that what really matters to you is the disc more than anything else. And keep in mind that, all the panelists have given valuable suggestions on how to deal with each case, and all of them are important. So good documentation, good follow-up, good counseling for the patient, and try to avoid missing patients who actually need treatment. So that's all I have to say, and thank you for a very lively webinar, Shweta and Mona.
Dr. Mona, I want to add one more point. I remember one of my case, he was progressing in spite of 4 or 5 medication, and he said it's better to die rather than having such a progressive disease. And then I told him that, did you got your cardiac checkup done? He said, okay, I am going regularly to my cardiologist and my pulse is low, and he said everything is okay. But then when I spoke to cardiologist that this patient is progressing very fast, and he put a pacemaker into that patient and he stopped progression. So that we have to be like very vigilant. Actually, sometime in our busy practice, we don't speak much to the patients and don't get into the depth of the diagnosis. So putting a pacemaker and making his pulse from 54 to 72 was like really a good thing for him.
You treated both the heart and the eyes.
Not I by myself.
I want to add one thing, like for the audience. Diagnosing NTG is really challenging, and so we need to have we need to take a good history. So, if there has been any history of trauma or any steroid intake, so these are all secondary glaucomas which mimic like normal tension glaucoma. So we need to rule out all this. So establishing the diagnosis and then managing is one aspect. Diagnosing itself, there is a lot of issues, and as Dr. Chandrima Paul said, it's a diagnosis of exclusion. So we need to rule out all other factors. It could be a old uveitis case, So with normal pressures and cupping, so similarly trauma, all the changes, now the pressures are all well controlled, and it's all in the normal range. Same way the steroid induced, the steroid effect goes off, and but then the cupping, whatever the damage is done, that shows up, but then the pressures are in the normal range. So these are all the secondary glaucomas which we really have to rule out by a good history taking. This I thought I should insist on. Thank you. Otherwise, all the cases that were presented were all established NTG cases. So, but then you might face a situation that where the diagnosis itself is not so easy.
I think we have a question from Shahinur. Do you have any experience in treating normal tension juvenile glaucoma for everybody, I think?
I think normal tension juvenile glaucoma is rare. If you see somebody with the glaucomatous defect in young age, you have to rule out something else that's going on. It could be a secondary cause. It could be you need to rule out a neurological cause. You need to rule out everything else. Rarely there is you do get patients with, let's say, an OPTN1 mutation, familiar, where they can get very early NTG pictures. But otherwise, NTG is really not a disease of the young.
So have you seen any case?
I have a few, yes. But see, if you're seeing 50 NTGs, adult NTGs, you might see one. They're that rare. And you have to be very, very careful.
I was actually unaware of this entity, but then I have not seen also, and I read about it. So I just thought I'll ask.
It's very rare. Most of them you find out are not really NTGs, there's something else going on.
Yes, Dr. Rani is saying correctly. I also saw one patient who had been advised trabeculectomies, diagnosing NTG in a young age. But then when we went for an MRI, because he was carrying CT and MRI with him, but maybe not that good quality. And when we did an MRI repeat at our center, it was pituitary. So we have to take it with a pinch of salt that whether it's really an NTG or something else.
Yeah, and the disc field correlation you need to see.
So this patient, he had a total pallar disc and an absolute field defects, which are very advanced. The patient I'm talking about.
Yes, yes.
I think in all cases, we have to rule out neurological causes. Burned out glaucomas and intermittent angle chloride glaucoma can mimic this kind of a thing. And of course, then masquerades and post-steroid usage, so all these things have to be looked into. So I think it's been a wonderful discussion. I really enjoyed being a part of it, actually.
I think we can keep on doing, and maybe another
Yes, no. So I think already we have crossed the time. So I would take this opportunity to thank everyone on behalf of Dr. Manoj Mathur sir. Sir has not been able to join us due to unavoidable reasons. Thank you, Santosh sir and AIOS, for giving us this opportunity. My deepest gratitude to our chairpersons, Dr. Pathophysiology sir, President AIOS, Dr. Ronnie Joss sir, Dr. Satyan sir, President GSI, and our esteemed panelists, Dr. Chandrima ma'am, Dr. Sibyl ma'am, Dr. Subhashini ma'am, and Dr. Gursatinder Singh. Our presenters, Dr. Shahinur, Dr. Shifali ma'am, Dr. Vanita ma'am, Dr. Sushma ma'am, myself, and Dr. Mona ma'am. Would also thank my co-moderator again, Dr. Mona ma'am, for all the coordination and execution. Thank you all for sparing your time on Saturday evening. Thank you for being with us. Thank you. Good night.
Thank you. Thank you. Thank you. Thank you.
Thank you, Shweta. Very well organized.
Thank you.
so
Thank
much.
you. Thank